All right, so welcome everybody to today's webinar, Staff Competencies and the New Requirements of Participation. It's not just in-servicing anymore. Today's speaker is going to be Kathy Hurst. Kathy specializes in providing legal and consulting services for skilled nursing facilities and assisted living facilities in California and Arizona. In addition to being a licensed attorney, Kathy's also a registered nurse, and her areas of expertise include human resource management, risk management, quality assurance and improvement, OSHA programs, state and federal regulatory and administrative compliance, litigation management, coordination and assistance with outside counsel, compliance and privacy programs, and day-to-day operations management of contracted facilities. So without further ado, I'm going to turn this over to Kathy.
Good afternoon, everybody. Welcome to the webinar. As you know, we're going to be looking at staff competencies now with the new requirements of participation, and it really isn't just in-servicing as we know it. We have always kind of been of the belief that, well, we'll in-service our staff, they'll sign for the in-service, and therefore they'll do their job. And it hasn't always worked out well for us in some areas, and it won't probably work out well for us with the new requirements of participation. You can go to the next slide. I can't. Next slide. I am doing this on behalf of the law firm of Clark Hill, which I work for. I do have to put in a disclaimer. Unfortunately, you know how us legal attorneys are, and my chair of my healthcare practice group would have a fit if I didn't put a disclaimer in. So the materials presented are for your informational purposes only and not for the purpose of providing legal advice. You should contact your attorney to obtain the advice with respect to any particular issue or problem. Use of and access to the handouts or any links contained in the handouts do not create an attorney-client relationship between Clark Hill and the user. The opinions expressed at this presentation are the opinions of the individual author and may not reflect the opinions of the firm or any individual attorney. Next slide. Sorry about the legalese, guys. Okay, so at the end of the presentation, I'm hoping that you will have you'll have a better ability to differentiate between what is a competency and what is a skill. They're actually two different things. A skill is a portion of a competency. Hopefully you can identify the components of a competency training program and develop a facility-specific training and competency program based on your facility assessment encompassing the needs of the populations that you serve. Next slide. So before we get started, just remember the facility assessment. I know you all heard this. The facility assessment that we have to do has to assess all of the resources that we have at the facility, what our staffing needs are, what type of patients we serve, what types of disease processes we have, what type of all facility hazards approaches we have. The facility assessment looks globally at what our facility takes care of and what we need to provide appropriate care and services to our residents. Once that facility assessment is completed, that should be part of the drive to your competency-based training program. Because once you've identified the types of patients that you care for, once you've identified the clinical issues and clinical needs of your residents, that is a good jumping board, if you will, to start your competency-based training program. Why do we care? Well, we care because what are the benefits of training? Well, we have better quality outcomes if our staff knows what they're supposed to be doing. Our resident experiences tend to be more positive when they talk about your staff and the nursing home. You have a much more engaged workforce, and that comes from that whole adult learning principle. If you tell me why I need to know something as a nurse or as a CNA and how that's going to make my job better or better my patient care, I'm going to learn that because patient care and improving patient care is important to me, and I'm going to become more engaged. So engaging your workforce is a good benefit of training. We get some loyalty and tenure We find that the more training and education that we can provide to our staff, there tends to be less turnover in our staff because they are getting trained and they're getting updated and they're getting that support on an ongoing basis from the management and the education team. It affects our community reputation because if we don't do good patient care, that obviously gets out in the community. It can attract some partnerships for us, and it can affect our public reporting measures, especially related to our 5-star program and our quality measures and some of those outcomes. Because if we have a lot of negative outcomes because of a lack of training, it will show up on our 5-star program. Next slide. So why do we have a competency-based training? Well, because it is a significant part of the new requirements participation, and it will be a factor in determining deficient practice during your surveys. Now, let me qualify that. When the survey team identifies a potential deficient practice, they will be, under the new survey process going into effect on November 28th, be looking at critical pathways for determining whether or not a facility is non-compliant in a particular area. For example, if they're looking at Foley catheters, they're going to use the Foley catheter critical pathway to determine whether or not the facility has complied with the regulation. Part of that determination of deficient practice is going to have to do with the competency and the skill sets of the staff caring for the patient with Foley catheters in the previous example. Finally, it's an outcome of the required facility assessment as of November 28, 2017. Specifically, the regulation says the facility assessment is, in part, for the determination of sufficient number and competencies of staff. That comes directly from the regulation. So competencies become very important when looking at the outcome of the required facility assessment. And the facility assessment is due on November 28, 2017. However, the facility will not be required to give it to a survey team until their first annual certification survey on or after November 28, 2017. Next slide. Okay, so what's the link between staffing and competency? So staffing, we have RNs, LVNs, CNAs, and RNAs. The competencies piece is who needs the specialized education, what kind of return demonstrations we have, and what are we observing in the clinical setting. You can have all the staff in the world. You could have a PPD of 7.5, but if all of your staff are not competent in performing patient care, it doesn't matter how many staff that you have, because none of them can provide the appropriate care and services. I've seen buildings with a whole bunch of staff who have very poorly trained nurses and have very bad outcomes. I've seen facilities that barely make staffing what I consider safe levels of staffing, yet their nurses are very competent and able to care for their patients, and they have very good outcomes because of their competent staff. So staffing is only one piece. You can have all the staff you want, but if they're not competent, and they don't have education, they haven't shown you that they can do a process, and you haven't observed it in the clinical setting, you may have issues with your patient outcome. Next slide. So let's look at nursing services and what are the highlights. Well, we have competencies and skill sets that our nurses have to have. Before they go out on the floor, or as long as they are employed by us, we have to have competencies and skill sets for them to take care of our patients. They need to assure our resident safety because the nursing staff are the ones taking care of the patients. And while everybody is responsible for resident safety, remember that 70% of all the staff in your nursing home is going to be nursing. So they're the ones that are going to be primary in assuring resident safety. And it has to be in accordance with that facility assessment. You may say, well, my administrator hasn't done our facility assessment yet. What am I going to do? We'll get there. And it's okay if your administrator hasn't done it or your corporate team hasn't helped you finish it. You still can get started with your competency-based training program based on other information. Next slide. So what are competencies? Well, the definition of a competency is a measurable pattern of knowledge, skills, abilities, behaviors, and characteristics that an individual needs to perform work roles or occupational functions successfully. What do we use competencies for? Well, we use them for assessing and selecting candidates for jobs. We use it for assessing and managing employee performance. We use it for workforce planning, and that would be based on your facility assessment. And we use it for employee training and development, and that's from the U.S. Office of Personnel Management. We do use it for training and development because if we find that there is a particular issue with resident care, say, for example, the licensed nursing staff does not know how to properly calibrate a blood glucose meter, and therefore the blood glucose monitor readings are off for the residents. Well, we're going to use that to develop a competency work plan. So what is that going to look like? It's going to look at the skills needed to perform that blood glucose testing, and it's going to be looking at the return demonstration and the competency to develop the staff so that they know how to properly calibrate that machine, measure the blood glucose, and know the reading that they are getting is probably an accurate reading. Next slide. So is there a difference between skills and competencies? The answer is absolutely yes. Both are similar in that they will both identify an ability a nurse has acquired through training and experience. For example, I can start an IV, but they're not identical in definition and function. So let's look at the next slide and we'll separate them out. Skills define what, and the competencies define how. So what's the skill? What's the competency? The competency, for example, is mopping a floor. And if you look at mopping a floor and performing wound care, they're both skills. We need to agree that mopping a floor is a skill set and performing wound care is a skill set. But the skill doesn't tell us how. The how is the competency. How does the employee perform the job successfully? How is that desired result obtained? So let's look at cleaning the floor. Anybody can pick up a mop and mop a floor. That's a skill. The competency is, did the employee put up the wet floor signs? Did the employee mop on the appropriate side of the wet floor sign? Did the employee change the water and or the mop head at the appropriate time during mopping the floor? Did the employee use the proper solution for mopping the floor? So the mopping of the floor is the task. The competency is doing the task properly. Looking at wound care, I can do wound care, and every nurse has been trained in wound care, but did the treatment nurse go to the treatment record? Did the treatment nurse review the order? Did the treatment nurse set her tray up, his or her tray up with all of the supplies needed to do the wound care? Did that treatment nurse disinfect the work surface? Did they put down a sterile setting, assuming one needs to be? Did they walk in the room and sanitize their hands before putting on gloves? Did they introduce themselves to the patient? Did they explain what they were going to do? Did they keep the field aseptic? Did they properly dress the wound? Did they dispose of the used materials properly? That's the competency. It tells us how they did the wound care. So I think hopefully that clears up the difference between a competency and a skill. Competency will provide the missing piece by translating the skill into behaviors or a behavior that demonstrates the ability to perform the job competently. I will go out on a limb and say all nurses can pass a medication as a skill. Not all nurses are competent in medication pass. Maybe they didn't do the 8 rights of medication administration, so he said it's only 5. Well, no, it's actually 8. The 8 rights of medication administration. They didn't sanitize their hands before and after. Maybe they forgot a blood pressure before giving an antihypertensive. So now that you understand the differences between skills and competencies, I think now it'll make more sense as to why we just don't in-service anymore. Next slide. Another major difference between your skills and your competencies is one of scope. Competencies will define the requirements for success on the job in a broader, more inclusive terms than skills do, as we've already found out. Think of skills as one of several facets that make up the competency. So how many skills, if you will, are required in properly changing a dressing to a pressure injury? Just think about how many skills are there. There's tons. How many skills are there to drawing up insulin? Well, I've got to clean the top of the multi-dose vial. I have to read the label of the vial. I have to, I'm supposed to, depending on, or I don't even know if we still do it, I'm supposed to inject air into the vial. I am supposed to withdraw the amount of insulin that I need, right? I'm supposed to recap the needle, and then before administering it, I'm supposed to check my order, identify see how many, so now we see how many components there are to the competency of actually drawing up and giving insulin. And competencies will be based on their position in the organization. Clearly, mopping a floor doesn't have as many skills, if you will, as detailed patient care tasks such as wound care or medication administration or clinical assessment. Next slide. What's knowledge? Knowledge is a little different. Knowledge is a clear and certain perception of something. It's an act, a factor, a state of knowing, it's understanding, and it's through formal training and experience. For example, I know that Arizona is, I know that when I drive to Phoenix, Arizona, it's 637 miles from my house. How do I know that? Well, I know that through experience because I drive to Phoenix and I know how many miles and how long it's going to take me to get there. That's how I got that knowledge. I received my nursing through formal training, but how many of you, when you took your nursing training, for those of you who are nurses on the webinar, which I assume most of you are, you would get training in the classroom and you had knowledge, but that didn't mean you had a skill or competency because now you had to apply that knowledge to effectively learn a skill to be competent in a practice. Next slide. So what's knowledge versus competency? Knowledge and educational training are pre and post tests. We're all familiar with these, lecture and videos. During orientation, how many facilities use a multitude of videos for orientation, whether it be your legal duty, which we're all really sick of right now. We might do privacy by video. We might do infection control by video. That's just giving me knowledge. It doesn't give me a skill. It only gives me knowledge. The competency is going to require actual application of the educational material presented. So how do you know if your new employee understood and used their knowledge to obtain a competency? So here's a good example. A brand new employee of a building who had only been employed 1 week noticed another CNA providing what she believed to be inappropriate care to a resident. She thought that it just wasn't right. She couldn't define it as abuse, but she thought it just didn't look right. So she immediately reports it to the administrator of the building, and tells the administrator what happened. The administrator takes it as an allegation of abuse, reports it accordingly to the Department of Health Services, and follows policy and procedure from there. That brand new individual, who was a brand new CNA, who had never worked as a CNA before, did she learn a skill or a competency from her orientation? Yes. When she learned about inappropriate conduct with residents and what to do with that information, she did it. That's how you know. How do you test every piece of knowledge? You can't. It's going to be impossible. But based on the needs of your facility, the types of residents that you have in your facility assessment and other information, you can figure out how to test the competencies, if you will. It may not be anything formal. It may be something very formal. Next slide. So here's another example of knowledge versus competency. Mary attends a class on early identification of sepsis. Mary takes a pre-test and she scores 65%. After the class, Mary scores 95%. That's knowledge. I took the class, I learned about sepsis, now I have the knowledge. Mary is told by a CNA that a resident who is normally calm is very agitated. Mary completes a CAM assessment, the confusion assessment method, for delirium, and then reviews her guide to sepsis. She notes that the vital signs are stable, but the temperature is greater than 100.9, and her heart rate is 96 and a respiratory rate of 92. The resident had a PICC line inserted 2 days prior. Mary calls the physician and gets labs ordered, an IV started, and 1 dose of broad-spectrum antibiotic. The resident does not get transferred to the acute hospital, and the resident avoids a septic event. Mary has now shown the competence. She learned it, and she had knowledge, but she didn't understand what to do with the information. Now she takes that knowledge and she competently applies it for a positive outcome for a patient to avoid transfer to an acute care hospital and avoid a septic event. Hopefully that clears it up a little bit more. Next slide. Okay. Some examples to specific competencies. You can look at Health Section 483.40. They're the new FTAG 740 to 745. There are some competencies that are actually listed in this section. They want people to be competent to care for those with mental illness. Now, this is assuming, of course, you actually admit people with mental illness. I'm going to assume you do. Caring for those with psychological disorders, competencies for non-pharmacological interventions. How do we handle a disruptive patient? How do we handle an agitated, combative resident? And caring for those with a history of trauma or post-traumatic stress disorder. You'll notice it says 2019. That competency will not be required until November 28th of 2019. Next slide. Okay, so what are some common core skill sets in nursing? Well, some common skill sets are communication. We need to know how to talk to people. Assessment and intervention. That doesn't mean they're competent. They might have the skills to do it. They might be able to use a stethoscope. They might be able to take a blood pressure, but they may not be competent. Advocacy, being a resident advocate. Collaborating with other members of the healthcare team. Human caring and relationships are a skill set. And critical thinking is definitely a skill set. So those are the common core skill sets in nursing. Most competencies are going to come from one of those 6 skill sets. Next slide. So what are some general components of competencies? Well, we have to have some knowledge. We can't be competent in something we have no knowledge of whatsoever. We have to have some skills. We have to have some performance. May not be the best, but we have to have some. Experience comes into play. So if somebody says to me, Kathy, can you go start an IV on the patient down the hall? I'm going to say, well, gee, I've got the skill, I've got the knowledge, but I haven't had any experience in that in 10 years. So I might not be that competent at putting in that IV. That's not true, by the way, but just so everybody knows, that's an example. Leadership and potential. Those are all some kind of general components of competencies that we need to think about. Next slide. So what does your competency training plan need to look like? What can you do to develop a competency training program? Next slide. Okay, so where do I start? Oh my goodness, where do I start? Well, when you're developing your competency training program, you need to look at your survey tools. You need to look at your internal reports. You need to look at, when you look at your survey tools, look at your 672, look at your 802, look at your Casper reports, look at your nursing home compare reports, look at your pharmacy reports for internal reports. How many of you look at your pharmacy reports, QAPU reports, litigation and incident, MDS extraction reports? This is where you start. It doesn't mean it's where you end. It's where you start. And then I didn't put the facility assessment on here because I'm going to presume that most of you haven't gotten your facility assessments completed, and I'm going to presume, since they're not completed, you're not using them to develop your training program. So how do you look at your training program? Next slide. Let's take a look. First of all, let's look at the 672 and the 802. When you look at the 672, remember that's the form that talks to you about how many residents are incontinent, how many residents are dependent for ADLs, how many tube feedings are there, how many residents have dialysis, how many residents have a vent tray. We all know what that is. So let's focus on the areas that you're triggering high on your 672. In the new survey process, the 802, which is the roster matrix, is changing. Let's look at your focus medications. These are all medications that are going to be a focus of the new survey process and will be required to be reviewed for new admissions. And if no new admissions have those drugs, they are going to pull a limited record review specifically for patients on these drugs. And they include antipsychotics for patients with diagnosis of dementia. That will come up on their quality measures, by the way, or on your Casper. Hypnotics, anxiolytics, antidepressants, anticoagulants, insulin, opioids, and respiratory drugs. If you have an awful lot of antipsychotics in your building, are they there because you have legitimate reasons for giving them, such as schizophrenia, Huntington's, or Tourette's, which they wouldn't even show up on your quality measures? But are you giving them to patients with dementia? If so, that's going to be a focus of competency. What are we doing not to give those medications? What are we teaching our staff about a behavioral intervention, or looking at how do we intervene with residents with behavioral problems who have dementia, other than chemically restraining them with either an antipsychotic, a hypnotic, an anxiolytic, or an antidepressant? For insulin, look at all of the things that entail with your diabetics. Is everybody on a sliding scale? Is everybody competent in blood glucose monitoring and blood glucose training? Several buildings in a couple of districts have just gotten IJs for that because somebody wasn't calibrating the blood glucose machine properly. And the surveyors now know how to go in and look at the memory. Somebody from Assure told the surveyors how to go in and look at the memory in your blood glucose meters so they can determine how many quality control checks the facility missed. And they're calling IJs on it. I don't know. Falls. Look at your 672 and your 802. Your 802 now has a section for falls. And it's not just falls with major injury now, all falls. They're looking at pressure injuries. Do you have a skin program? Do you have a lot of wound vacs? These are residents that will be looked at initially upon the tour of your surveyors. And those are competencies that your staff is going to have. What competencies does a staff have to take care of a wound vac? I'm going to be honest with you, I don't even know how to change a wound vac. So if somebody asked me to do it in the building, I'd say, I don't know how to do it. You have to show me how. It's not a skill I have, and not only do I not have the skill, I'm therefore not competent. How about IVs, trachs, ventilators, enteral feedings? These all are skill sets, but they require competencies. For those of you on the call that may have a subacute unit, the ventilator, the trach, those are usually 8-hour. You have, if you have a subacute unit, you have specific competencies that you have to do just based on the fact that you're a subacute. If you have a subacute in your building, that's a good jumping point for how to do competencies for the non-subacute section. Dementia care. How many of you are using your hand-in-hand toolkit? Remember, CMS at one point was, and I think they still are, doing dementia care surveys. The surveyors are expecting that we are using that hand-in-hand toolkit. As you know, California requires 5 hours of education per year for all CNAs in dementia care. The hand-in-hand toolkit has 6. The one you can eliminate is the one on abuse. Why can you eliminate that one? Because you're already training your staff on abuse and neglect with your legal duty, the policies and procedures that your facility has, and you're reporting a reasonable suspicion of a crime in a nursing home under Section 1150B of the Affordable Care Act. So you don't have to do the abuse reporting in the hand-in-hand toolkit because you're already doing it in a number of ways. So there's your 5 hours right there. CMS endorsed even. ADL dependence. How many of your residents are having issues with late loss ADLs or declining in their late loss ADLs? What are the late loss ADLs? Eating, transfer, toileting, walking. If you're noticing that a lot of your residents are starting to decline in their late loss ADLs, what are we doing to train our staff or make our staff competent to take care of those residents so they either can slow the decline or so that we can provide additional care and services to avoid some of the decline? Now, clearly, if you're an Alzheimer's dementia unit, that's going to be a different question because everybody in your unit is supposed to decline. The question is, was the decline avoidable? And is our staff competent to help them maintain their ADL status for as long as possible? How about your bowel and bladder retraining programs? Is your staff competent to do that? If I ask any CNA in your building about a resident on a bowel and bladder training program, will they be able to tell me what that resident's pattern is and when they're supposed to take that resident to the bathroom and what that training program entails? Will the licensed nurse be able to say, well, we do a 3-day voiding monitor. From that, we develop a plan of care, and then we communicate that to the CNAs, and the CNAs document the times that they're supposed to take the resident to the bathroom and whether they're wet or dry or they're continent, and then we evaluate them at the end of each week to see if they're improving. That's a competency. That's knowledge. The competency is, did they do it? So that's an example from the 602 and the 802 that you can use to help you with some competencies. Next one. Next slide. Next one. Casper Reports. Let's look at your quality measures. Your quality measures are a big key to how your facility is doing on a clinical level. Do you have a lot of patients on hypnotics and anxiolytics? Do you have a lot of patients that have pain or report moderate to severe pain? Do you have a lot of residents who are losing weight? What about your facility characteristics report? I had one building I looked at the other day that had what I thought was a very odd number of patients under the age of 30. So what kind of competencies do we need to care for a younger population when we're used to caring for the average age in our facility has traditionally been, 78, what competencies do we have in place to care for residents who are in their 30s or their 20s? If you have a subacute, how many of you have subacutes and have very young patients that are in there because of some traumatic event, motorcycle accident, car accident, gang shooting, something like that? How are you teaching your staff how to take care of those patients? Also on your Casper report, it's going to talk to you about where these individuals come from. Are you getting a large number of patients from ID or DD facilities? Your facility characteristics report, again, the age of your residents, who is on hospice, how many people do you have on hospice or palliative care? How many people have a discharge plan? Survey reports are always important. What were your last 3 years of surveys? What did they look like? Did you have repeat tags? Were they in patient care areas and things that show that we maybe didn't know what we were doing to take care of our patients? Nursing home compare reports. These are your quality measures. But I go on the nursing home compare reports too. Improvements or decline of function. Remember, two of the things that we're looking at on the claims is how many patients go to the emergency room and how many community discharges do we have and how many hospital readmissions do we have. I know in another facility, we had a very high readmission rate of over, it was something like, 23% of all of our patients were being readmitted within 30 days. And we had to go back and look at why are all these patients being readmitted in less than 30 days? What is it that's going wrong? Well, for a few, they were probably discharged a little too soon from the acute, but the majority of them were transferred out because of sepsis. So the question was, are we not catching sepsis before it becomes sepsis? Are we not catching it at the systemic inflammatory response level where we can do something at the nursing home level? And what we did is we trained our nurses on early identification of sepsis and looking at systemic inflammatory response, and the readmission rate dropped dramatically, like by half in the first 90 days. So again, looking at how many patients are going to the emergency room. Why are they going to the emergency room? Is it a change of condition that we should have assessed? Was it avoidable? Well, the resident had abdominal pain. Okay, what's the competency for abdominal pain? Did you look at the last time they had a bowel movement? Did you do a bowel assessment? And did you do it in the right order, which is what? Inspection, auscultation, percussion, palpation. Did they do it in the right order? Did they document that assessment? Or did they just say, well, resident has abdominal pain, notified MD and transferred out? That's not a competency. The skill is there. Oh, the patient complained of abdominal pain, I called the doctor. But there's no competency because nobody looked at why the resident had that pain. So we can get a lot of information from our claims-based measures like our emergency room visits, community discharges, and our return to hospital in 30 days. Those are all metrics that your hospital will keep. And if you have an electronic record, they're probably embedded in that electronic record. Next slide. When you look at pharmacy reports, and if you have an electronic record, you can probably pull this up. How many medications are you giving in your building with black box warnings? Do the licensed staff know what those black box warnings are? They should. How is that communicated to them? If I go up to a nurse and I ask that nurse about giving Seroquel to a patient who has dementia with behavioral disturbance, can that nurse tell me about that black box warning that specifically applies to a patient with dementia? What about the pharmacy reports and medication pass observations? Remember that I told you medication pass is a skill. The competency is being able to set up your cart, take your cart down the hall, open your MAR, look at your MAR, identify the drugs you have to give, pull the right drugs, verify the drugs, put the drugs in the cup, verify it again, put the cart away, go in the patient's room, identify the patient, sanitize your hands, go in the patient, see I can't even do it off the top of my head, sanitize your hands, go in the patient's room, identify the patient by whatever method or means that you use in your building, whether it's an armband or photograph, give the resident the medications and wait for the medications to be taken. And if any medication requires an assessment, like an antihypertensive, did they do a blood pressure? Then did they go back out, dispose of what they had in their hand, and then document that they gave the meds? That's the competency, which consists of all the skills. QAPI reports. What kind of QAPI projects is your facility working on? Are you working on falls? Are you working on weights? Are you working on care plans? Are you working on customer service? How to answer the phone? What type of QAPI reports is your facility working on? Use those as a training board. Litigation and incident reports. Look at incident logs for trends. Now, nobody's required to have an incident log. There's no regulation to keep them, but we all have one somewhere that we don't give to surveyors, I hope. But anyway, we have incident logs. If you notice that all the falls are occurring between 5 and 7 on the PM shift, something else is wrong. That can lead to a training program or a competency program. What current lawsuits do you have and what are issues alleged? Somebody said, well, I don't ever know what the lawsuits are. You know, most facilities, if I talk to any staff, they go, yeah, we heard that patient was suing us. They'll be able to tell you what the issues were. Well, I'll tell you what happened with that patient. Use current lawsuits as a springboard for a learning experience. I do it all the time, and not because I'm a lawyer and not because I'm a compliance officer in my other buildings, but because I think they're good learning experiences, because nurses don't always understand what part of the competency they got wrong. But I took good care of the patient, and I monitored their blood sugar, and I took their blood pressure, and I did this, and I did that. Yeah, but you didn't document this, or you missed this. And of course, MDS extraction reports, which you can get from your electronic record, for example, you can use those. How many patients, I want you to give me a list of every patient who has a physical restraint. I want you to give me a list of every patient who's on an opioid narcotic. I want you to give me a list of every patient who has a stage 2 or greater pressure ulcer. Those are your MDS extraction reports. So you still don't even, I still haven't even mentioned the facility assessment, you notice. So the facility assessment's important, and you do want to use it. But in the interim, if you want to kind of get going, here's a good place to start. Next slide. Also consider new equipment and tasks. For example, did your facility just get a new lift? You probably need to train them on how to use that lift. Did you get a new blood glucose meter? Did you require your nursing assistants to do a new task? For example, maybe your nursing assistants never had to serve trays to feeders. I don't know, I'm picking something. Well, now they have to serve a tray to a feeder. That's a new task. What's the skill and what are the competencies you need to perform that? Well, they can't pass the tray and then sit the patient up and then give the patient a utensil and give it and help they'll eat. That would be part of the competency. What about your unplanned discharges? When that goes back to your emergency room visits and your readmissions after 30 days. What kind of unplanned discharges are you having? Do you have 5 people a month going against medical advice? What's wrong? You can consider those. I look at AMAs all the time. They're not that common, but when they happen, I look at why they're leaving. More often than not, it's things like, I never wanted to be here in the first place, let alone any nursing home. I'm going home. Goodbye. Okay, bye. Look at your new admissions. Do they have something new that your facility is not used to? So, for example, I had a facility call me the other day, and they said, we would like to take a patient with Bladder irrigation, can we do that? And my response is always, it's not prohibited by our regulation, but is your staff competent and capable to care for bladder irrigation? If not, no, you may not admit. If you can train them immediately and they can be competent, yes. And the response I got was, never mind. So apparently we didn't want to admit that. What new programs are you offering in your building? Are you going to now be doing a respiratory program or a cardiac program? Or are you going to be doing the music and memory program? You would need to train and make sure people are competent in those new programs that you're offering your residents. What type of mandatory training programs do you have to do? Well, we all know the mandatories under Title 22. We got dignity, we got cultural competency, we got, abuse and neglect, we've got privacy and security, we've got our compliance programs, there's a laundry list of mandatory training programs. You say, I can't fit another training program on my calendar, I just can't do it. I know I can't do it. That's fine. Look at your calendar and figure out how you can bring some of this into your already existing training programs. Revise and re-evaluate or redo some of your current training programs. So for example, if you have issues in your building with late loss ADLs, you can make that part of your program under your Title 22 training requirements about ADL care that you have to do. So roll it into an already existing program. Nothing says that you have to be doing training and education and competency 7 days a week, 365 days a year, every hour of every day that you're at the facility. That's impossible. You'd never get orientation done. You'd never get anything else done. Of course, if you're a staff developer, you usually have a multitude of tasks to do, and a lot of them are the infection control individuals or experts in the building as well. So no one's saying that you have to write a calendar and do training every single day that you're at work. Look at what you have and tweak it in development and make it fluid. So you say, well, today I've got this program that's working really well. I'm going to add this stuff to it because I got a problem here, so I'm going to make this part of this program. So that's something you can do. Look at your geriatric and your chronic conditions, such as geriatric assessment, the chronic conditions we get, COPD, CHF, diabetes, heart failure, peripheral vascular disease, issues with chronic constipation, dementia, behavioral issues, all of these things that are part of the geriatric residents that we look at. And then look at your staffing patterns and your nursing hours per patient day. Remember I said, all the staff in the world isn't going to take care of your patients. You can ask for more staff all day long, but if they're not competent, you're not going to have any better outcomes. You're better off having a little less staff, as long as you're meeting whatever regulations you must meet, and having extremely competent staff and providing better outcomes. I went to see one building that was a 99-bed, typical kind of nursing home, averaged about, 10, 12 Medicare a day, and had a couple of HMO and some long terms. Based on their acuity, I would have expected staffing to be about 3.4, 3.5. They were staffing, I'm talking 3.22 to 3.3 at the most. If they went over 3.3, somebody was in trouble. But their staff was extremely competent, so the outcomes for those patients were very minimal, if any. In fact, they were providing outstanding patient care. They had good quality measures. They had low readmission rates, but their staff training program was phenomenal. They were always training and working with their staff, either on a one-to-one level or trying to make sure that everybody was competent to take care of the patients that they had. And before they admitted new diagnoses or things people hadn't seen, they trained people, they monitored people, they had people there when those residents came in to make sure that they knew how to take care of them. So despite their low staffing, if you will, their outcomes were better than some of my buildings who are staffing at 5 and 6, simply because of the competency. So those are some things that you want to look at. Next slide. I know that there might be some questions out there. I know you guys are on mute. I don't know if any questions were submitted, but this is the time to ask questions if you have any. Oops, I don't have the little question key. Did you get any?
All right, Kathy. So yeah, we have one question right now to start, and yeah, as Kathy said, please use the questions function to submit any questions you guys may have at this time. So the first question we have here is, are we getting a copy of the PowerPoint after this, and can we access the recorded webinar again just in case, because this person missed the earlier part?
Well, I think that's a CAF issue. I don't have any problem with the PowerPoint going out. I'm assuming CAF is going to post that. Did we decide to record it?
Yes, so we have been recording the webinar, and as far as making a copy of the PowerPoint slides available, we can send a PDF version out to everyone that attended today so you guys can review the slides. And as far as the recording goes, I can also see about putting that up on our CAF YouTube page. So if you guys search on YouTube for CAF, you should be able to find the page, and I can post the webinar there. The next question we have is, how frequent do we need to do competency?
Wow. Well, I think it's going to depend on a number of factors, so use your typical lawyer answer. Sorry about that. Competency is fluid. So, for example, your nurses may be really competent on wound care, but today they got a new wound care vac that is purple and pink, and nobody's ever seen it before. Now you have a new competency. Once your staff is capable of caring for it, you're competent. So when do you have to do competencies? I would consider when you hire new staff. So for example, let's look at wound care. If you have 3 treatment nurses on duty or a treatment nurse on duty who's perfectly competent in taking care of wounds, and that would be evidenced by what? That would be evidenced by low infection rates, your wounds are healing, the IDTs are meeting. If all of those things are running real fluid, you probably wouldn't have to look at doing a competency until your treatment nurse says, you know, I think I don't want to work here anymore. I think I'm going to quit. And you have to hire a new treatment nurse. Now you have to look at his or her competency. There's no time frame in the regulations that say how often we do competencies. Once you believe your staff is capable and competent to care for an issue based on your facility assessment and all of the little tools you have at your disposal, you would need to revisit it periodically just to make sure, but you would be doing that because you would be looking at your QAPI reports, you would be looking at your CMS 802s, you'd be looking at the 672s, you would look at issues with admissions and discharges. You'll know when that competency has fallen through the cracks. For example, I went to a building the other day, and they were doing such a wonderful, wonderful job on falls management. But unfortunately, I don't know what happened. All of a sudden, it all was terrible. They had no fall management program at all. I said, what happened to the program? Well, you know, so-and-so that was supposed to do this, and she quit, and then the other person kind of just didn't follow through. So that right there is like, well, if you were looking at the falls and you were following them, you would have seen that the competency declined and something needed to be done to intervene again. Fortunately, I came in early enough in the game that I said, boy, you guys got to start working on this and working on it fast. And so that's what they're doing now. So there is no set time for how often you do competencies. And competencies may or may not be quote unquote documented, but I would certainly look at your facility assessment when it is finished and say, okay, what competencies do I need? And is there something I need to either revisit, or is there something I need to start? I'm just going to give you a heads up on the blood glucose now. The IJs are coming out quite a bit with blood glucose monitoring. So there's a good competency for you to make sure you got one.
And Kathy, this person just wanted to clarify, this applies to CNAs and licensed nurses, correct?
That is correct. And then it might be correct, though, for housekeeping. Remember my mopping scenario? What if the housekeeper is going into the room and they're not mopping with the proper solution for disinfecting? Or what if they're using the wipes to disinfect, but the stand time isn't long enough? So if you notice that, that's something you can take to your environmental services supervisor, and they can work on that. certainly the staff developer in the building doesn't have to do it all, but competencies will apply to everyone at some level. For infection control purposes, we do need to kind of stay on top of housekeeping because we've got those dwell times for the disinfecting solutions, and if they're not leaving the solution on long enough, it's not getting disinfected, and that would be a problem under your infection control tags and your antibiotic stewardship program. I'm not sure if that answered the question.
I think that covers it, Kathy. Thank you. Does anybody else have any questions? I'm not seeing any more here in the questions queue.
If anybody has any questions, you can always go to the Clark Hill website and find my biography, and there'll be a link there to contact me.
All right. Well, thank you, Kathy. I guess we'll wrap things up for today then. Thanks, everybody, for attending. And yeah, once again, go to the CAF YouTube page, and I will make this webinar available hopefully by the end of this afternoon. And I'll send out the slides, the PDF, the slides to everybody that attended today.
Thank you, everybody, for attending. It's nice. I'm glad you could take some time out of your busy day to do so.
All right. And thank you, Kathy.